Okay, so we're going to go ahead and start recording. Thank you guys all for joining us. Today is the cardiovascular review. It is probably one of the more difficult or tricky parts for those of us who aren't CVICU nurses, and I know there's a lot of you in the group today who are CVICU nurses. So as we're going through, I'll be the first to admit I've never worked full-time in a CVICU unit. I've floated there multiple times. I've had plenty of training and book knowledge. But I'll be the first to admit it's not what I've had my experience in. So if I get something wrong or you have something to add about anything, again, throw it in the chat, unmute, and share with the group. I am more than happy for you guys to participate and add where your knowledge is and where I'm lacking. So again, I have these numbers up. This is just if you want to text me or Caroline with any questions during it. And Caroline's going to be monitoring the text from you guys. Okay, so to start off, this is just to kind of show you where I got the material or why I chose to focus on what I'm focusing on today. This is the test plan updated for 2020 for the Pediatric CCRN, and it is 14% of the test. So that is a bit of a change from the test plan from 2015. It was, I think, 50% of the test. So they did move acute pulmonary edema from cardiovascular to respiratory. So that might kind of account for that 1% question. Oh, hi, Brinley. I've got my little one here.
Hi.
Oh, hi. Belle is here helping today as well. She's a little 4-month-old, almost 5-month-old teacup Yorkie. So she's a big 3-pound girl. Smaller than a lot of hard NICU and cardiac babies. So she's here helping today. If you hear any tiny barks or squeaks, it's probably her. Anyway, so this is the kind of outline of what I use to order test content. So it's 14% of the test and goes over all these things. I'm not going to list them out right now because we're going to go through them. The only, I will say, I don't do a lot with the last couple: myocardial conduction, obstructive shock, and vascular occlusion. Because the other content kind of takes up a lot of time to get through. So I'm hoping we'll get through enough or through everything today so we can do all of the practice questions that I've kind of put together for you guys to go through. The test plan, in addition to kind of listing out that stuff, it also shows you testable actions. So this is the testable actions from the CCRN test plan from their handbook. This is the general stuff. And then, oh, I didn't put a slide with the cardiac. There is some cardiac specific things as well. So before, go ahead and mute yourself, even if you're not muted.
A name change for Baroli. So
I'll mute you. All right, so before we can start with all the abnormal things, you really have to have a good understanding of normal heart and general cardiac principles. To me, the most helpful thing, not being a CVICU nurse, is really getting a handle on what normal function looks like so that then when you start learning what the abnormal things are, even if you don't know everything about it, you can then kind of figure it out. So we'll start with normal heart anatomy first. So this is the pathway of blood through the heart. And it's kind of numbered out here with the blue and red arrows to indicate when it's deoxygenated blood and when it becomes oxygenated blood. So first, you're going to have blood returning from the body through the vena cava, both superior and inferior vena cavas from the upper and lower parts. All that blood's going to dump into the right atrium, here number 2. From there, it flows through the tricuspid valve into the right ventricle, which then pumps through the pulmonary valve into the pulmonary artery. That branches off and goes to the right and left lungs, and then the blood becomes oxygenated, goes through the alveolar bed, the capillary bed in the alveoli, blows off CO2, ideally gets oxygen in, and then returns to the heart through the pulmonary veins. And so you might remember from nursing school, like this is the pulmonary artery is the one artery that's meant to have deoxygenated blood, and the pulmonary veins are the only veins that have oxygenated blood. So that oxygen-rich blood comes back to the heart from the lungs and goes into the left atrium. From there, it's pumped through the mitral valve into the left ventricle, and then up through the aortic valve into the aorta and through the body. So that's the normal pathway of blood through the heart. There's a bunch of different elements of heart functions. That's the anatomy. This is the physiology. You have hemodynamics, cardiac output, stroke volume, your preload, afterload, compliance, and contractility. So these are all different elements that are going to affect how well your heart is actually functioning. So we'll go through each of these really quickly. So hemodynamics is basically determined by pressure, flow, and resistance. So blood, like any other liquid, is going to follow the path of least resistance. Anytime it can, it's going to go from a high pressure to a low pressure. And that's given that it has the right openings, the right connections. So blood flow specifically inside the heart is a result of pressure gradients and differences in the different pressures of the different parts of the heart, and then the actual contractility or pumping of the heart itself. So just a note about pressure gradients, it's usually, or it should be, normal heart, the pressure is going to be lower on the right side than it is on the left. And resistance is going to be less in the pulmonary circuit than the systemic circuit. So the resistance that the heart is pumping against as it pumps to the lungs is going to be less than the systemic circulation. And if you look at like what a pulmonary blood pressure should be versus your systemic blood pressure, it's always going to be lower. It should be lower. And then the presence of any abnormal communications, and communication, you might see that word, but it's just any connections or openings, any way that the blood can go, that any abnormal communication is going to lead to shunting. And then it's always going to shunt from higher pressure areas to lower pressure areas. So cardiac output, the definition here is just the volume of blood ejected from the left ventricle in 1 minute. So there's a formula for it. The cardiac output equals your heart rate times your stroke volume. So we'll talk about stroke volume in a second, but the amount of blood you pump with each pump out of the heart times the number of times it pumps in a minute. So when you have good cardiac output, you're going to have good tissue perfusion. And you can see here it varies from 200 mLs per kilo in a neonate to 100 in adults. So relatively, neonates have higher per kilo, than adults do. They also, just as a side note, are very heart rate dependent for their cardiac output. Adults have a lot more ways to kind of compensate for their cardiac output in other ways. The only way that infants and small children really do it is through their heart rate. So you'll see a lot of heart rate variation as they try to adjust and compensate if they need more cardiac output. So next we do have stroke volume. I think I skipped. So cardiac output, it's going to be influenced by all the things we're about to talk about. So your preload, your afterload, the compliance and contractility of your heart. And then you might see something about cardiac index, but that's basically your cardiac output divided by your body surface area. So stroke volume. So that's the first part of cardiac output. And it's just, again, the volume of blood ejected from the left ventricle to the body with each contraction or ventricular beat. It's usually 60 to 75% of the volume that's in the ventricle at the time. And it's affected, again, by preload, by contractility, by compliance, and afterload. So all those things kind of go into it. So preload, this is the volume of blood in the ventricles at the end of diastole and right before contraction. So we also call it the filling of the heart. The blood comes in, diastole is the rest period. So at the end of rest, right before it contracts, how much blood is in the heart, that's preload. It's determined by, first of all, the blood returning, how much blood are you actually getting back from the body? That's going to be a big part of it, but it also is determined by the cardiac fiber length and stretch. And that's just like how well the heart can expand to fill up to get that blood. Is it expanding enough? Is it expanding too much? How, you have to have a size of a container and volume to put in it. Those are the two things that kind of affect then how much you're left with at the end of diastole. You can measure, if you wanted to measure preload, it can be measured with cardiac or atrial lines or during a catheterization for a diagnostic catheterization. But we kind of, most of the time you'll just see it indirectly measured as a CVP. So the higher your CVP, theoretically, the higher your preload is going to be. So while we're talking about volume, this is just a chart of Starling's law. So this is kind of the idea that in order to improve cardiac output, we need to improve our volume status in a normal patient. So when they don't have cardiac output, giving them more volume should help, which is why when we have low blood pressure, you'll see, for the most part, fluid boluses and things like that. But cardiac patients are a little bit of the exception to this rule. Sometimes they do need volume, but sometimes, as you see, if you get too much volume, especially in a heart that doesn't function normally, you're going to see a decrease, a drop off in their function of their heart. So, but basically, Starling's law says that cardiac output's directly related to venous return, and that's the most important factor of preload. So an increase in preload will increase your cardiac output until the very high end. Again, too much, once you get to a certain point, too much volume is just going to make it worse, especially in cardiac patients. Volume can make them worse. So that's the most important thing to remember about preload and cardiac patients. So you can have alterations in your preload come from, again, variations in your volume status, and then your systemic or pulmonary hypertension. So if you're having hypertension, which typically you think of as like afterload after the heart, that still causes a backup, and it can still, extra pressure in the system is going to affect your preload and the ability to fill back up. High amounts of PEEP can affect this too. If you think about how much pressure you're putting into the lungs, that makes it harder for the heart to open up as much as it should and fill up as much as it should. So higher PEEPs are going to kind of compress the heart, making it harder for it to expand and fill up. Dysrhythmias, any kind of unorganized rhythm of the heart is going to make it hard. Again, when you don't have that rhythmic opening and closing and contraction, it's not giving, possibly not giving enough time for the heart to fill back up. And then all of the vasopressors and inotropes and things that we use can affect preload as well. So how do we increase preload? Again, volume administration is the main way we do this. So we give crystalloids, colloids, blood, whatever it is we want to give. There's a lot of innate mechanisms in the body to increase preload. So what does our own body do? How do we compensate? So there's renin-angiotensin that's secreted, antidiuretic hormone, aldosterone, catecholamines. All of these things are things that our body secretes to try to affect our own preload. And that usually is affecting our volume status, either, through how much water we're either holding to from our kidneys, or how much we're then dumping off if the preload's too high. So how do we decrease preload? So first way is diuretics, Lasix, hydrochlorothiazide, whatever it is. ANP, BNP, this is, I always say it wrong, natriuretic peptides, but that's your body's natural way to kind of regulate sodium and water balance. So again, that's kind of your innate mechanisms that do things. They vasodilate, and they also have an effect on your kidneys that either holds on to your sodium and water or lets it go. Vasodilators are another thing we can give. This is going to enlarge the vessels, and if you think about it, you have a system that's a certain size, your vascular system. If you vasodilate, it opens that up, which increases the amount of space to fill, which increases the amount of volume you need. So if you vasodilate, you're kind of enlarging the whole system, which then has an effect of making it less volume in the system. And afterload reduction, just like hypertension can affect it negatively, we can positively affect preload with afterload reduction as well. Kind of it's all connected. So afterload. So this is the workload the ventricles have to overcome, and it's your systemic pressure, whether it's the pulmonary system or your actual whole body system. So you can measure it depending on which system you're looking at. You can either look at systemic vascular resistance or pulmonary vascular resistance. And there's some formulas on here. I don't think you're going to need to memorize these formulas necessarily, but it just kind of helps understand the concept behind it. So your systemic vascular resistance, think about your blood pressure, which is your MAP, and then your cardiac output. So your heart has to push against that pressure. And so too low of a pressure means it's easy to push against, but too high of a pressure can be a problem too. And the MAP, again, it's your mean arterial pressure is dependent on your volume and the elastic properties of the arterial wall. So if your walls get too dilated, either from medications or some process that's happening in the body, If they get too relaxed and they dilate themselves, then that's going to decrease your MAP as well. So how do we increase or what do you see increased afterload with? So hypertension, whether it's systemic or pulmonary, polycythemia, which if you have too high of a hemoglobin or hematocrit, that's going to affect like the viscosity of the blood, and thicker liquids in any form, whether it's blood or not, are going to flow slower. So polycythemia makes the blood thicker, makes it flow slower. It doesn't flow as well, so it's going to increase afterload. Then outflow obstructions and vasoconstrictors. So just like vasodilators can decrease afterload, vasoconstrictors tighten up those vessels and increase afterload, increase that pressure that it's pumping against. Some things you can see decreased afterload in is septic shock, again, vasodilator use, anaphylaxis, and other physiologic factors, which we'll kind of get into. Okay, so compliance is the ability of the ventricles to stretch, to relax and fill during diastole. So there's kind of a relationship between your end diastolic pressure and your end diastolic volume. So basically think about a balloon and how difficult it might be to blow up. Some balloons are very stretchy and easy to blow up, and if you tried to like physically with your lungs blow up like a hot water bottle, you just couldn't do it. It's too stiff. So good compliance, is meaning large amounts of fluid only make a small change in the pressure inside. When you have poor compliance, adding just a little bit of volume can make a large pressure change. So the stiffer it is, the less compliant it is, the more pressure changes you're going to get with increasing the amount of volume, increasing or decreasing. So you see decreased compliance in a lot of different things. Myocardial hypoxemia, acidosis, that's going to make it harder for your heart to stretch. Congestive heart failure, hypertrophy, pericardial tamponade, again, that's like can cause pressure in that sac around the heart, makes it hard for the heart to stretch out. IP, that we've already talked about, and then inotropes as well. You'll see better compliance with medicines that reduce your afterload, such as milrinone. Last kind of component of heart function is contractility. So this is the squeeze. So you have the preload that fills you up. The afterload is how much pressure to pump against. The compliance is how well you stretch out and fill up, and the contractility is how well you squeeze and push it back out of the heart. So that is the squeeze is made by your myocardial muscles, your heart muscle. If you're concerned about contractility and squeeze, you can measure it with an echo that kind of estimates the amount of squeeze or contractility, and then a cardiac cath can directly measure that. First, you have your atrial contraction that fills up your ventricles, and then the ventricular contraction that pumps it out to the body. So you might see these terms shortening and ejection fractions, but this, let me just read the definition. So shortening fraction is the percent change in your diameter of your ventricle during systole and diastole. So it's usually 28 to 44%. So this is how well the myocardium has the ability to maintain contraction. So how much it kind of opens up. And then ejection fraction is how much it's then the stroke volume, how much it's pushing out. So that ejection fraction is the percentage of volume change with systole. So if shortening fraction is the change during systole and diastole, this is just the volume change with systole, which is with the contraction of the ventricle. So normally you should have, again, 50 to 70%. If you see, patients with very low ejection fractions, they're in some level of heart failure. So different factors that influence contractility. First of all, you have electrolyte imbalances. Think calcium is a big one that affects the heart. If your ionized calcium is low, and then your blood pressure is low, giving that is going to help. Your sympathetic stimulation. So this is your fight or flight, your body's internal fight or flight response. Those things that usually improves your contractility. But things that depress it can be sedatives and hypoxia or high CO2. There's a lot of different meds we give that affect contractility. Anything that affects the sympathetic nervous system, epi, norepi, other inotropic agents, all that's going to affect the the contractility of the heart. So what are some things, just to kind of list it out, things that can decrease it? Low calcium, low magnesium, low sodium, anything that's a negative inotrope, low oxygen, high CO2, your parasympathetic nervous system. So that if your sympathetic nervous system is the fight or flight that pumps you up, parasympathetic is what slows you, calms you down. Acidosis can affect contractility, which is why even in kids with normal hearts that have sepsis and high acid levels from lactate or CO2 or whatever, their heart function can be affected as well. Hypoglycemia, and then if they have a damaged myocardium or some innate heart disease. So things that increase contractility, this can be hyperkalemia, hyperglycemia, hypercalcemia, positive inotropes, and again, the fight or flight response. All right, so just a few pharmacological terms that you might kind of see. Again, the autonomic nervous system is that sympathetic stimulation. Think norepinephrine, epinephrine, things that increase your heart rate, contractility, conduction time. And then parasympathetic is the release of acetylcholine, and this acts on the vagus nerves. And if you think about vagus nerves, you think, the vagal effect, slowing down, slowing your heart rate. So adrenergic agents. So you have alpha and beta receptors, and you have meds that affect either the alpha receptors or beta receptors, either as agonists or antagonists. But alpha adrenergic is going to affect the cardiac fiber itself. The stimulation results in arterial vasoconstriction and causes increased intracellular calcium. But beta, there's two types of beta receptors, beta 1 and beta 2. But affecting the beta adrenergic is going to stimulate the SA node discharge. So think SA node is your heart rate. That's how fast or slow your heart is going to beat. So beta 1 is going to increase or decrease your heart rate depending on whether or not you're antagonizing it or stimulating it. And then beta 2 is smooth muscle relaxation. And it can also affect bronchodilation. Okay. So other few terms you might hear, vasoactive means it's going to raise or lower your heart rate or blood pressure. Vasopressors, usually that's trying to specify and drill down that we're really working on blood pressure. Inotropic is those alpha and beta receptors that either vasodilate, vasoconstrict, or enhance contractility. And then chronotropic is affecting the heart rate. Okay, so now is where we get into the actual test plan itself, now that we kind of have a baseline of the heart function and anatomy. So cardiac infections is the first on the list, and inflammatory diseases. So any acute inflammatory process can affect the heart, but there are some that are specific to the heart itself. So any myocardial disease that produces inflammation of the cardiac or vascular tissues is what they're going to cover in this section. So that's any of the itises, endocarditis, myocarditis, rheumatic heart disease, and Kawasaki. First, we have endocarditis. So this is an infection that affects the lining, the inner lining of the heart. So the endocardium, that's what's lining the inside, and this also includes the valve. So endocarditis can then affect and cause valvular damage as well. So this can cause, or usually is caused by bacteria or fungal entrapment. So you get the bacteria in the heart is affecting the heart lining itself, but it's also causing bacteria and fungus to kind of gunk up there, I guess, which makes turbulent blood flow and causes problems with the valves and lining. So it's all really irritated, and then that slower, more turbulent blood flow causes tissue damage, but it also causes the blood to, again, slow down even more. It causes platelet and fibrin formation, which then makes clots and can entrap circulating organisms. So it's just kind of a vicious cycle. That's kind of what it looks like on the heart. So symptoms of this would be a new or changing murmur. You also see fever and chills, just like you would with any infection. Fatigue, malaise, anorexia, or arthralgia, joint pain. It can lead to congestive heart failure and valve insufficiency because, again, you're damaging those valves, which makes them not work as well as they should. And then because you have that slowing of the blood and thrombus formation, you can get systemic emboli as well of those like either clot particles or clots infused with bacteria or fungus. So treatments for this include IV antibiotics for 6 weeks. You want to manage the symptoms of their congestive heart failure. If it's bad enough, they may need valve replacement. And the most important thing here is prevention. So you want to do good oral care and use of antibiotics for high-risk procedures in certain groups. Pericarditis. So if endocarditis is the lining on the inside of the heart, pericarditis is that lining on the outside of the heart. So when you, this is where you get an inflammation of that outer lining. If you think about what happens in any infection, kind of inflammation and pus and things like that, when that kind of stuff builds up inside the pericardium, that's where you can see a pericardial effusion. This decreases your cardiac output because as that sac fills up more and more with infectious material or just swelling in general, you kind of get that tamponade physiology where it squeezes the heart. So this can come from trauma, infection in other parts of the body that travel there, or toxic reactions to radiation drugs. You'll see decreased cardiac output. You might hear a friction rub or muffled heart tones because that swelling around the heart is kind of making it hard to hear their heart tones, and pain when they're supine. And you're going to treat possibly with aspiration, taking a needle in to aspirate the effusion, and antibiotics. So this is kind of what that pericardial effusion looks like. Last of the itises is myocarditis. So endocardium is the inner lining, pericarditis is the outer lining, and myocarditis is the muscle itself, the heart muscle itself. So this can cause temporary or permanent damage. It can be caused by a bacteria, virus, or fungus. And it's most associated usually with a viral infection that can either start systemically and then move to the myocardium, or it can start with endocarditis that then moves into the muscle as well. If they have any history of illness or this happening before, fever, tachycardia, arrhythmias, again, you're going to see congestive heart failure if it's severe enough, with lethargy, pain, weakness. So management's going to include treating the infection itself, supporting their cardiovascular system while they're recovering, and then maximizing their ventricular function. So usually the questions you're going to see about the itises usually refers to, this patient had, what puts them at risk for whatever. It's like a history of a valve replacement is going to put them at higher risk for endocarditis in the future because you have a foreign body in their endocardium, in that area. Or if they had some other kind of infection before or an oral procedure, things like that, that's going to put them at risk. Rheumatic fever. So this is an inflammatory process. It's an autoimmune response to group A beta hemolytic strep that's not treated well enough. So it's going to attack the collagen in the heart and cause valve damage. Usually it occurs 1 to 6 weeks after that strep infection, but 3 weeks is the most common. You usually see this in 5 to 15-year-olds. So to diagnose rheumatic fever, they have what's called the Jones criteria. So basically you have to have at least one thing from the major column and at least 2 things from the minor section to accurately diagnose rheumatic fever. Because a lot of these are kind of, general symptoms that could be a lot of things. So a major symptom would be either carditis, polyarthritis, chorea, which is sudden irregular movements, nodules in the myocardium, or erythema marginatum, which is a rash with raised margins. And then minor would be fever, arthralgia, elevated ESR, prolonged PR interval, positive for strep, or previous rheumatic fever. So what do you do to treat this? Penicillin is the standard treatment, also bed rest until their ESR is normal, which is just an indication of their inflammation in their body. You can give anti-inflammatory meds and then just emotional support. Kawasaki, this isn't as common as it used to be, but they do still like to ask questions about it. But this is an inflammation of your vascular tissues. So it's the most common cause of acquired heart disease among children in the US. And the majority of children that get this are less than 5 years old. Usually seen in spring or winter months. But this is, the common telltale things, and what you'll probably hear in questions is a strawberry tongue, fever for more than 5 days, plus at least 4 of these things. So conjunctivitis, rash, strawberry tongue, edema and erythema of the hands and feet that eventually then desquamation, which just means the skin then peels off. Cervical adenopathy, usually just on one side. And then you want to look at their cardiac status because this does affect the heart. So it can cause coronary aneurysms, effusions, ventricular dysfunction, and valve insufficiency. So how do you manage this? Serial EKGs, you want to keep a close eye on their coronaries, keep a close eye out for dysrhythmias. You can give IVIG if it can reduce coronary artery problems if you give it within the first 10 days. And then aspirin. So the one question I saw as I was going through practice questions was about giving aspirin for a kid with a strawberry tongue, which, normally in our practice, we think you never give aspirin to kids because it can cause other problems. But this is one where aspirin is the drug of choice, even for these kids that are less than 5. So first, you're going to start out with the anti-inflammatory dose and then kind of go to a lower antiplatelet dose. And then bed rest until they're afebrile for 72 hours. All right, next part of the test plan is cardiac malformations. So this is, AKA congenital heart defects. This is probably going to be, usually what I saw is a lot of questions on the test have to do with congenital heart defects. Because out of congenital abnormalities, this is, heart problems are the most common. Up to 10 out of 1,000 kids have some kind of congenital heart defect. So the first thing, again, just like you want to look at what a normal heart looks like before you can know what an abnormal one looks like, the other component of this is fetal circulation. So you kind of want to understand how fetal circulation works, how newborn circulation should change and work, and then you can kind of understand what's going to happen then depending on what kind of defect they have. So fetal circulation, you have intracardiac shunts, so things in the heart that aren't normally there that's letting blood go from one direction to another. They're going to have a high pulmonary vascular resistance where, like we said, in a normal heart after birth, you're going to have a low pulmonary vascular resistance. Here it's high. Their lungs aren't in use. You're not breathing through them. You're not really using them at all. So the resistance inside your lungs is going to be very high. And then the systemic resistance is going to be, by comparison, much lower. Your cardiac output is going to be relatively low, and gas exchange happens in the placenta versus the lungs. So the two shunts that are inside a fetal heart are the ductus arteriosus and the foramen ovale. So this is just kind of a picture of fetal circulation. As you can see, the blood is returning from the umbilical vein. Most of it goes to the liver, but the ductus venosus allows some of it to just jump right up to the heart. As it enters the right atrium, instead of most of it going into the right ventricle, which then goes to the lungs, you, again, don't need your lungs as much. So a lot of that blood is just going to shoot through the foramen ovale, which is just that connection between the atria. From there, it can then go through the left side of the heart and up and into the body. The blood that doesn't go through the foramen ovale, it goes into the right ventricle and the pulmonary artery. But instead of most of it going to the lungs, it can then connect through the ductus arteriosus to the aorta. So basically, those two holes allow you, the main point is they allow you to bypass the lungs. So your ductus arteriosus, that's the connection between the pulmonary artery and the aorta. It usually closes, or it should close after birth due to that increase in PaO2. So that baby takes that first breath, and that increased O2 opens up those vessels, kind of vasodilates them, decreases that pulmonary vascular resistance, and then it's going to affect the ductus arteriosus. You're going to lose the prostaglandins you were seeing from the placenta. So both of those things together cause the ductus to close, usually within the first 10, 12, 24 hours after birth. That's when it functionally closes. Anatomic closure takes up to 2 weeks, but functionally it squeezes up and is no longer used, or blood's no longer going through it within 24 hours after birth. If you have a PDA, that's when it doesn't close within those first 24 hours. So then you have a patent ductus, then we changed from just calling it a ductus to a patent ductus arteriosus. And in a newborn, without any other cardiac problems, a PDA will allow blood to go from the aorta back to the pulmonary artery. So whereas in a newborn, that blood is going from the pulmonary artery, instead of going to the lungs, which are too high a pressure, it's just easier for the blood to go through the ductus to the aorta. But in a newborn, those lungs have opened up, the pressure is much lower. So if you think high pressure then in the aorta, it's going to be easier for some blood to shunt back through the PDA in the opposite direction, back to the PA, and then to the lungs. The foramen ovale is, again, that opening in the mid-atrial wall. In a fetus, it's going to shunt the blood from the right side of the heart to the left, again, because the pulmonary pressure is higher. It's going to go to the low, it's easier for it to go to the left side of the heart than it is to the lungs. But once you're a newborn, again, with no other problems, it's going to shunt from the left back to the right because that pressure change has happened. Again, functionally, it closes a lot sooner than it anatomically closes, and functionally it's closed pretty soon after birth. But sometimes kids, it stays open, and it's called a patent foramen ovale, and sometimes they have what's called an intermittent. So just depending on pressure changes in the heart, most of the time it may not be an issue and there may not be a lot of shunting, but then something happens, they get irritated or other, physiologic changes happen, and then blood will start to shunt. All right, so when we talk about shunting, what are we talking about? So this is the movement of the blood in the heart. Usually when we talk about shunting, it's through some communication that shouldn't be there is usually when we use that word. So left to right, if you think about in a normal heart, again, the side is where the oxygen-rich blood has come back from the lungs.
William has a good question in the chat. He said, in children who require a PDA due to their cardiac defect, does the pressure differences in the heart help keep the PDA open longer compared to a patient who has a normal heart?
It would be great if it did. I think a lot of times it can, but sometimes it doesn't. And so then when the PDA starts to close normally, that's when a baby who might look normal at birth and in that first day after birth, they can look fine until that PDA starts to close on its own. And that's when you start to see them go into a cardiogenic shock or some kind of usually the baby just looks septic, but if you kind of can think of the timing of this is 1 to 2 days after birth, it's because their PDA is closing when they need it for survival. So good question. Okay, so shunting. So in a normal heart, that oxygen-rich blood on the higher pressure left side gets pushed back to the right. And that makes a little less oxygenated blood going out to the system, and then it makes more higher oxygen level going back into the lungs when it doesn't need to. Your body's still getting oxygenated blood. So this is we call these acyanotic defects. When there's left to right shunting, this happens when there's something else going on that makes those pressures or holes not normal. So when something else is increasing the pressure, it's going to make, and we'll go over these defects later, but whenever you get a right to left shunt, it's shunting deoxygenated blood away from the lungs and into the systemic circulation. So the body is going to receive blood that's not oxygenated as much as it should be when we call these cyanotic defects. Okay, so again, shunting is going to be is a vascular resistance to flow. So anytime you have vascular resistance one way or the other, it's going to affect, again, which way you shunt. So vasoconstriction is going to decrease the flow that happens and possibly shunt away. Vasodilation increases the flow and makes it easier to shunt to it. Okay, so when should you suspect a congenital heart defect? So this is when you see a murmur and cyanosis. Again, not all defects are going to be cyanotic defects, but especially if you see both of those things. If crying worsens the cyanosis, they fail a hyperoxia test, which is just a way to say that giving them, if you have a baby who's getting cyanotic and you give them oxygen, it makes them worse. That's a good indication that it could be a congenital heart defect. Any abnormal weight loss or poor feeding with tachypnea, because feeding is hard, or it takes up a lot of the baby's energy. And if they don't have a heart that's working as well as it should, it's going to make feeding very hard for them. So they might not be able to feed as well. They may have to stop too soon, get very sweaty, and they're going to have a hard time gaining weight. If you see differences in their upper and lower pulses, or if you see, like I said, what looks like a septic appearing infant. So they come in, they look kind of shocky. You don't know why yet. Could be sepsis, but it could also be a congenital heart defects that's really showing its ugly horns. There's a lot of genetic disorders that are associated with heart defects. This kind of lists it out here. One of the ones we see a lot is Down syndrome, and that has that atrioventricular septal defect. And we'll go over later what most of these are. Trisomy 18, you're going to see VSDs or hypoplastic left heart syndrome. Turner syndrome, you're going to see VSDs, coarcts, aortic stenosis, hypoplast. Williams has supravalvular stenosis. DeGeorge syndrome is interrupted aortic arch, and Noonan syndrome is pulmonary valve stenosis. And usually the questions you'll see related to this is just, it'll tell you that it's a Downs or some other thing and give you a bunch of random general symptoms. And basically it's kind of pointing you to look for a cardiac cause for that. So how do we classify congenital heart defects? There's kind of 4 major classifications. So there's 2 and then 2 under each one. So there's acyanotic and cyanotic defects. So acyanotic, thing A is lack of cyanosis. So this is going to be defects that do not cause cyanosis. You have a normal SAT, some other problem. So with that, you can either see ones with increased pulmonary blood flow or ones with a ventricular outflow obstruction. And then the other category is cyanotic defects. And these you do see a decreased SAT. You're going to see cyanosis. And that you can either have increased or decreased pulmonary blood flow with those. So some terminology that you'll see throughout, we'll go ahead and go over now. Atresia means that something is missing or it didn't develop, but it's not there. Stenosis, on the other hand, means that it is there, but it's too stiff, usually referring to either a tube, like a vessel, or a valve. Hypoplast means something is small and not developed. Septal is just referring to a location, so it's somewhere in the septum, either between the atria, so the atrial septum, or between the ventricles as a ventricular septum. Anomalous means something's wrong. It's either the wrong connection, wrong direction, something like that. And then tetralogy means 4. All right, so now that we got basic terms and concepts down, let's go through all of the different defects. So first, you're going to start with acyanotic with increased pulmonary blood flow. So there's a few in this category. You see, you have your VSDs, your ASDs, your AVSDs, and your PDA. First is your ventricular septal defects. This is, they might ask a question about this. It's the most common congenital heart defect. So this is going to be right here, a connection between the ventricles. So in that ventricular septum is a hole where there shouldn't be. I don't know if I can. Yeah, right here, if you can see me circling. So what happens with this, if that's the only abnormality you have, then there's still going to be higher pressures on the left, still oxygenated blood on the left, and that hole is going to make that blood flow then from the left to the right. So there's still, that's why it's called increased pulmonary blood flow. So the blood is going to, some of it is going to shoot back out, not all of it, but some of it's going to shoot back through that hole and then go back to the lungs. So you're going to see more blood flow to the lungs than you normally would. My mouse is like hidden. And sorry, I'll figure out how to get rid of that little circle where I annotated, but my mouse is invisible right now, and I can just see where some things are happening. But anyway, so for VST, sometimes it may not require a repair, but if you go too long without repairing it and it's severe enough, you can develop some heart failure, some pulmonary hypertension, because again, the lungs are seeing more blood flow than they should. And then sometimes you only require monitoring, but surgical repairs can include a patch or a suture closure. And usually their post-op course is uncomplicated. once they have the repair, it can affect their AV conduction. Because if you think about it, if you think about the normal conduction of the heart, the the conduction's going from the SA node to the AV node, and then down through that septum to the rest of the heart. So you can have some AV conduction issues and arrhythmias after repair. Next is the ASD, and this. Let's see if I can. There. You see my mouse? Sorry, I can't see the mouse pointer to get that to go away. Let me try to figure this out for a second. Well, in the meantime, the ASD, instead of, it's crazy. Let's get either way. Remind me not to annotate again. That messed me up.
Can you see your mouse now?
Huh?
Can you see your mouse now? I see it moving across the screen.
Oh, can you tell me where it is? Tell me when it gets up above where it says CCRN.
Right. Okay, stop right there. Oh, stop right there. It's right below where it says normal heart.
Okay, let me go up and over.
It's under Acrobat now. It's under the light bulb. It's on the light bulb.
Oh, why is it not letting me click? I'm trying to get it to the drop down at the top. Well, this is great.
If you unplug that keypad and use that one, will it go forward?
Maybe. I see where it's letting me drop down. Okay, this is. Oh, saw it up there. Wow. Sorry, technical difficulties.
It's very close to home. Now it's not. Can you see it at all?
No, not at all. Caroline can't see it either. Can somebody else, if you can look, sometimes it has you request to annotate. Someone try requesting to annotate. Let me see if something will pop up. Okay, because right now, I can't make the slides go. Ooh, approved.
Thanks, Taylor.
Thanks, Taylor. Okay, is it letting you annotate at all? Ooh, there's that. Oh, hi. Thanks for the heart. I see this sidebar that's like, Will you open the WebEx app and see if you can take over hosting? It wouldn't bother me, except now I can't control anything else except the annotating. Or just Google like how to stop annotating. Okay, so ASDs, I'll just talk about this since it's on the screen. I don't know how to get past it in a second. Is a connection between the atrium instead of the ventricles. So that is gonna allow, again, if that's your only defect, it's gonna allow blood to flow from the left side of the heart to the right side of the heart. So it comes back from the lungs into the left atrium. Some of it is gonna go through that connection back into the right atrium, which again goes back into the lungs, causing increased pulmonary blood flow. Now, ooh, I fixed it. All right. Sorry about that. Always learning something new. Don't annotate. That's what I learned. All right. Thanks for your patience. Back in action. Okay. Next, let me see if I had any other notes about ASD since I got all distracted. So this is one, if you're doing a cardiac cath, you might see higher SATs than normal in the right atrium and right ventricle and higher pressures than normal in the right atrium because there's too much blood flow coming back into it. It may not need to be repaired if it's small enough. It may not be a problem. Actually, some kids don't even know they have this till later in life. But you might, some reasons you might need to repair or close this would be if you have right ventricular volume overload. So you're going into kind of almost a right-sided heart failure because you're seeing too much volume. You can see arrhythmias depending on the size of the defect. It might be affecting conduction through the atria as well. And then if you have any problems with clots at all for some other reason, or you're seeing clots develop, this can be a problem because it can also, normally it shunts from left to right, but it can be a conduit for a clot to come into the atrium, shoot to the left side, and go out to the body, which can cause a stroke. Okay, so AVSD is an atrioventricular septal defect. So this is going to be one large opening kind of in the middle of the atrium and ventricles. It's going to affect those valves as well. So, you can kind of see that the mitral and tricuspid valves aren't able to develop like they should either, which means they're not able to close all the way and prevent, so they're going to be insufficient, which means they're going to let blood flow back up through them when they shouldn't to. This is a big problem. This needs to be repaired, and usually soon in life. And again, this can be a common defect in Down syndrome. And I think this is, some people call this an AV canal, or it used to be called an AV canal, but all the stuff that in reviewing this time, this is the terminology they use. So this is probably what you would see on the test. This is a more complicated repair, obviously, than either an ASD or a VSD is. It needs surgery. The VSD, usually they close it up with a patch. The ASD close with a patch, and then they have to repair those valves and make them, back like they should be. Because you're doing so much work in the septum and in those valves, you can see arrhythmias afterwards. And they may need further surgeries and further repairs later in life as they get bigger. Last of this section, the acyanotic with increased pulmonary blood flow, is a PDA. So this is when, for whatever reason, their ductus arteriosus doesn't close, it stays open past when it should. You can see this a lot in premature infants, but with no other defects present, it causes a left to right shunt. So the blood in the aorta, that's a very high pressure vessel, is gonna, some of that blood will shunt back down to the pulmonary artery and then into the lungs. We can close this with medication. So the medication you use to close this is indomethacin. And if that doesn't work, you can do surgical ligation as well. And usually these are pretty simple procedures and not many post-op complications. All right, next group of acyanotic defects. So again, normal stats. These are ones with a ventricular outflow obstruction. So first of all is aortic stenosis. So aortic stenosis refers to the valve, the aortic valve. And in this, usually you can see kind of this top picture, a normal aortic valve. It's going to have 3 leaflets and be able to open nice and wide and close fully. But when you have stenosis, it's going to be stiff and narrow. A lot of times you'll just see 2 leaflets instead of 3, but it's not going to be open all the way. They're going to be too stiff to open all the way, but also usually too stiff to close all the way too. So the more severe it is, obviously the higher need for a surgical repair. So it just depends, again, as with all of these, how bad is it depends on whether or not and what kind of repair you need. But they can do, I believe, cardiac caths to kind of, open it up. But if it's too stenotic, they might need to do a more surgical repair. Okay, next is a coarctation of the aorta. So this is a narrowing of the aorta. You can kind of see on this picture, the dotted line is how wide the aorta should be. And with a coarctation, you're going to see a narrowing right here. A lot of times it's where the PDA or the ductus used to connect. Sometimes the aorta doesn't form as well as it should at that specific point, and it's too narrow. So sometimes you can have a wide variety of symptoms. Again, it depends on how narrow it is. But it's basically going to affect your perfusion in your lower extremities. So if you think of your aorta, you have the aortic arch. Those branches coming off the top of the aortic arch, it's what feeds the head and the arms. And then as the aortic arch goes down, that feeds the whole lower part of the body. So you're going to see lower maybe fewer or weaker pulses in their legs, but also this is where you get kind of four extremity blood pressure, and your upper extremities are going to have a higher pressure than your lower extremities, because a lot of the blood is getting shunted up to the top of the body and not as much to the bottom. So if it's a critical coarctation, they may present in a shocky picture where they really have very low pressures in their lower extremities. They might need prostaglandins to keep that PDA open if that's helping to feed that aorta, the constricted aorta. But they probably, if it's that critical, they're going to need a surgical repair. And that PGE is just a bridge to a surgical repair. Afterwards, the biggest thing, and the thing you probably will see a question about, is post-op you need to monitor for hypertension, because there's a lot of receptors in the aorta, the lining of the aorta, that affect your blood pressure. So your body, that's kind of where your body's sensing the pressure coming out of the heart and whether it needs to, raise or lower your blood pressure intrinsically. So when you start mucking around with that vessel and, cutting it or patching it or whatever it is, those receptors get affected, and sometimes you can see hypertension because they're overstimulated. So that's the biggest thing to look for with this post-op. Next, our last acyanotic defect is pulmonary stenosis, and sometimes you'll also see this as a right ventricular outflow obstruction, right ventricular outflow tract obstruction, sorry. But anyway, pulmonary stenosis, similar to aortic stenosis, it's a thickening or narrowing of that pulmonary valve. So as the blood leaves the right ventricle, it goes through the pulmonary valve into the pulmonary artery. So it's a thickening, narrowing of that valve. Depending again on the severity of this, it makes it very, very hard for the right ventricle to pump into the blood. You kind of think as the left ventricle is the powerhouse of the heart, it's used to pumping to the whole body. That's a big job. The right ventricle has an important job too, but pumping to the lungs is typically a lot easier. And so to have that much pressure that it has to pump against is going to cause problems in the right ventricle down the road. It can cause hypertrophy, right heart failure, all of that. So sometimes they can just do a balloon valvuloplasty, so a cardiac cath, kind of put a balloon in there and like pop it open. But they can, if that doesn't work or it's too severe for that, they may need surgery. And we'll talk later about kind of general post-op principles for all of these surgeries. Okay, next section is cyanotic defects. So these are the ones you're going to see lower SATs. So all of these up till now, if those were your only problems, you're going to have your baby's still going to have above 98% normal SATs. With these defects, you're going to see lower saturation. So the first one is ones that have decreased pulmonary blood flow. So this is tetralogy of Fallot, which they like to ask about as well, and tricuspid atresia. So first, tetralogy of Fallot. This is one of the ones you're probably just going to have to memorize if you don't deal with it all the time. But tetralogy again means 4, so that means there's going to be 4 defects that are involved with this. So when you have all 4 of them together, that's this defect. So first of all is pulmonary stenosis. So that's kind of what we just showed with the last one, but it's all the other defects that go with it that make it cyanotic. So this narrowing of the pulmonary valve, pulmonary stenosis, that's number 1. Number 2, right ventricular hypertrophy. So again, the right ventricle is having too much of a hard time pumping like it should. It gets, that muscle gets hypertrophy. And whereas, all the other muscles in your body, you want them to be pumped up and big, and you think of that as a better thing for your heart, it's not a better thing. If your heart muscle is too big, it's not going to work as well as it should. An overriding aorta. So since the blood really can't get out of that pulmonary, out to the pulmonary artery, the aorta starts to kind of override into this VSD. So a large VSD is the 4th thing. So you have this large VSD. The right ventricle is not able to pump out through into the pulmonary artery like it should. So this aorta kind of grows to override it, and more blood goes out into the aorta. So this is the reason this is classified as decreased pulmonary blood flow is, again, because it can't get into that pulmonary artery.
William just sent a good mnemonic he's heard.
So a good mnemonic he's heard for TET to remember the defects is PROV, you have TET. Like PROBs or PROV.
I like that.
PROV, pulmonary stenosis, right ventricular hypertrophy, overriding aorta, and VSD. Good
Thanks,
one.
William.
Thanks, William. That's a good one. Prav. So this one, you can have a wide variety of clinical manifestations. It really depends, again, on how narrow that pulmonary stenosis is and how much blood then can or
I'm
cannot.
supposed to read like prove. That's way better.
Prove, that is better.
Thanks.
Prove you have TET. Prove it to me.
I'll remember that.
PROV. Good, thanks for clarifying. So anyway, it depends on how bad the pulmonary stenosis is, but these kids need surgical repair. It's a very complicated and lengthy repair, and it's normal to have, you're going to have probably some right heart failure post-op, because again, you're already seeing this hypertrophy, which is affecting the right, the function of the right side of the heart anyway. So once you repair it, you're probably going to see some right-sided heart failure afterwards, and you may see some dysrhythmias, again, because you're repairing a lot of areas where the normal conduction would go. So those are some things to look for afterwards. The biggest thing that, or a question they like to ask regarding this is about TET spells, and I'm sure even those of us who aren't cardiac nurses have heard of TET spells. But the answer is going to be knee to chest position, probably. But basically, a TET spell is a hypoxic spell. It begins with irritability. If basically the patient gets mad, it causes pressure changes in the heart. So as they get more mad, their lungs can kind of clamp down even more, making it even harder for the blood to flow into the lungs, which is then going to make their hypoxia even worse. So it's thought to be caused either by a spasm of that outflow tract, that right ventricular outflow tract, or a sudden drop in their systemic pressure. So one way or the other, either all of a sudden they get mad, they clamp down, the blood has a hard time going into the lungs, or something all of a sudden makes it a lot easier for the blood to go to the body. But either way, it's not going through the lungs and it's not getting oxygenated. So usually the answer, if you see a question like this, is going to be a knee to chest position. So you're putting their knees up to their chest, you kind of squish them in half. But what that does is it increases systemic vascular resistance. It's kind of closing, you're contracting the legs up to their chest, which then kind of clamps down those vessels. It makes it harder for the blood to flow into the body, basically, which then hopefully will overcome the pressure resistance and make it go back into the lungs. You can give them some supplemental oxygen, because oxygen, with cardiac babies, just remember, oxygen makes blood want to go to the lungs. It vasodilates, and sometimes that's a bad thing. A lot of times it's a bad thing, but for these kids in a TET spell, that's good. You need it to get some blood into the lungs. Especially morphine, because it has vasodilation effects as well. Giving them some volume, or sodium bicarb, because acidosis makes it worse. Propranolol, because it relaxes infundibulum. I had to look up that term, but that's it just refers to that whole right anatomy, the anatomy of the heart, all of the structures, the ventricle, the septum, all of the valves. But propranolol can relax it, and phenylephrine. But probably, if they ask a question about this, again, knee to chest. Okay, next one is tricuspid atresia. So tricuspid refers to the valve. That's the valve, again, between the right atrium and the right ventricle. Atresia means it's missing, it's not there. It's not just stenotic or narrow, it's just not there. So on this picture, you can kind of see they just made it as a wall, whereas these other valves have little openings. So that if it didn't develop, the blood cannot flow from the right atrium to the right ventricle. So the right ventricle doesn't even really develop in utero, because it's not needed. So with this is one of those that is not compatible with life unless there is some other defect along with it. Basically, you have to have somewhere for that blood to flow. So it needs to have either it keeps a patent foramen ovale after birth, or you have to create some ASD. So one of the first things you might see for this is they need surgical repair early in life, usually in the first week of life. They can go in and do a cardiac cath to kind of open up an ASD or make the PFO bigger. That's a first step, but they need surgical repair. So basically what the blood is going to flow from the right atrium to the left atrium, and then down into the left ventricle, which then kind of does the work of both. So it's going to pump blood into the pulmonary artery, into the lungs, and also into the aorta. Those valves are both kind of next to each other and come from the left ventricle. So then what happens with this is some of the blood goes into the lungs and then comes back again to the left atrium and then mixes with that blood from the right atrium. So that's why it's kind of shown as purple here. So you have deoxygenated blood coming back. Some of it gets into the lungs and comes back red, but that's again mixing with the blue blood. So then you get purple mixed sat blood going out to the body and to the lungs. Okay, so last group. This is cyanotic defects with increased pulmonary blood flow. Sorry, Belle just got, she's my little guard dog and she probably heard something outside, some tiny little barks. Okay, so cyanotic with increased pulmonary blood flow. So these things, again, they're gonna have lower sats, but they're gonna have increased blood flow rather than decrease. So you have transposition of the great arteries, truncus, total anomalous pulmonary venous return, and a hypoplast. So transposition of great arteries, even if you didn't know what this was coming into it, you can kind of think through the words. So transposition means something switched. Great arteries are the two big arteries out of the heart. So the aorta and the pulmonary artery have been switched around. So instead of the pulmonary artery coming off the right ventricle, it's the aorta. And instead of the aorta, and again, the pulmonary artery then is coming off the left ventricle. So you can see it in this picture. The problem with this is another one that's not compatible with life, because you then have two parallel and not communicating blood flows if you don't have any other defects. If that was allowed to be your only problem, you'd have blood returning from the body to the right atrium, going into the right ventricle, and then out through the aorta to the body. So you have the right ventricle just having blood flow to and from the body, and then the left ventricle has blood coming back from the lungs like normal, going into the left ventricle, and then out to the pulmonary artery to the lungs again. So the left side of the heart is only communicating with the lungs, the right side of the heart is only communicating with the body. So with this, you have to have either a PDA or an ASD or both. You have to have something to let that blood mix with each other. Otherwise, you're just going to have deoxygenating blood going through the body and oxygenated blood going through the lungs. So you'll need surgery initially to at least create the ASD so blood can mix. And so then what you'll have happen is that the blood's coming back from the body, blood's coming back from the lungs. It at least mixes in through the atrium and then goes to the ventricles, and again, out the wrong places, but at least you're having mixing. That's still going to be a lot of work on the heart, so later you'll need a full repair to switch back those arteries. But it's a very long, complex repair, has a long post-op course. Truncus arteriosus, so instead of those two arteries being switched, they didn't fully develop and separate out like they should have. They kind of start, in early fetal development, they kind of start as the same and ideally split back out. This is where they didn't split out. So you have this large trunk of a tree kind of thing that is the base of your aorta and your pulmonary artery. So they kind of just have one big valve, one big trunk, and then they split off. You'll need some kind of opening. There's always going to be a VSD present ready with these. So the blood comes in from the right atrium, left atrium into the ventricles. It's going to mix here where that opening is and just pump straight up that trunk and split between the body and the lungs. So because you have that mixing and you're going to have, again, a cyanotic defect, lower sats. This is, again, a very extensive repair. It's one of the most complex of the repairs. Okay, total anomalous pulmonary venous return. This picture kind of shows the most, I guess, dramatic of it. From what I read, there can be different levels of it. It can be total, it can be somewhat partial, but so you have the pulmonary veins, instead of returning to the left side of the heart, They basically return blood back into the vena cava in some form, and it comes back to the right side of the heart. So you have to have, this again needs to be a very quick or repair soon after birth, because you don't have any blood coming back to the left side to go into the body. You need other defects as well. So you'll have an ASD here. That ASD is the only way for blood to get to the left side of the heart, since the pulmonary veins are not coming back to the left side. Though from what I read, again, there can be like variations in how severe this is. So there might be just some of the blood coming back to the IVC and some coming to the left side of the heart, or all the way up to total where it's all going back to the IVC or SVC. So yeah, you have to have the ASD to let it into the left side and then out to the body. So it is going to mix, because all the blood's coming, the blood coming back that's red is going to mix in the vena cava. And then that mixed blood is going to either go back to the lungs or through the ASD into the left side of the heart to the body. This repair, again, this is pretty rare, but it does need to be repaired soon after birth. Lastly, and one of our favorites is hypoplastic left heart syndrome. So I know we see a lot of these, and we see a lot of them for a long time because it's a multi-stage repair to get them back to something that's functionally normal, even if it's not normal. So you're gonna, again, this is one that has several defects that are a part of it as well. So it's 4 components again, basically. There's gonna be mitral valve stenosis. So the mitral valve between the left atrium, left ventricle is very narrow. There's going to be aortic stenosis and atresia of both the aortic valve, and that first little branch of the aorta is usually very underdeveloped. A coarctation of the aorta, which again is a narrowing of the aorta, and then a hypoplastic left ventricle. So this left ventricle really doesn't develop at all. A lot of these are being diagnosed in utero now, so we kind of are prepared for them. But if it's not, for some reason they didn't have good prenatal care, or it wasn't caught, usually you'll see them present within a day or so of life in a shock-like state. So as their PFO and PDA start to close, this goes back to your question, like, it'd be great if they stayed open, but usually as they start to close is when we start to see problems. So they're going to need prostaglandins to keep those open until we can do the first stage of repair. This is one that you want to be very careful with oxygen use. In general, with cardiac kids, you want to be careful with oxygen use. I mean, caveat to that, you want to know what their problem is. Some it's not a problem, and some it's a big problem. This is one where oxygen can be a big problem for them, because what is happening, okay, so you see the normal heart on the left. On the right, blood comes back into the right atrium and into the right ventricle, and all of that anatomy is normal. It goes to the lungs, and then as it comes back to the left ventricle, though, or the left atrium, the left side of the heart, there's just not enough there for them to pump out to the body. The aorta is too narrow to really pump to, and there's really no left ventricle to pump. So the blood is then, that means all of that makes higher pressures. It's too hard to pump, it's not going to pump. So the blood is then going to shoot back through an ASD or a PFO back into the right side of the heart. It's going to mix there, and then from there come back up into the pulmonary artery. So this is why you need a PDA in order to get blood to the body. You need the ASD to get blood from the left side of the heart, and then you need the PDA to get blood to the body. So the first stage of this repair, what happens if there's too much oxygen? Again, oxygen is going to attract blood flow. If you have too much oxygen as it's coming up the pulmonary artery, it's going to be way too easy to go to the lungs. Way too much blood's going to want to go to the lungs, which is going to make less blood go through to the aorta and less to the body. So that's why you really want to avoid too much oxygen with these patients. It'll increase their pulmonary blood flow and decrease their systemic blood flow. Okay, so the 3-stage repair, a lot of times we hear the names of these instead of stage 1, 2, 3. The first is a Norwood with a BT shunt. The second is a Glenn or a bidirectional Glenn. And the third is going to be a Fontan. So first stage, you really want to try to fix, the goal of this is to fix the aorta and to improve pulmonary blood flow. So they do a graft of the aortic to kind of reconstruct it. And they really kind of use the pulmonary artery as then an aorta. So they patch the PDA, they kind of close off the connection of the pulmonary artery. They use that to make the aorta, and then they make a BT shunt from the aorta off to the pulmonary artery, the rest of it. So this allows for improved blood flow to the heart or to the body, and then some passive blood flow into the lungs with the BT shunt. Of course, you can see, you know, this I'm sure is not exactly to scale, but relatively the BT shunt's relatively small. Once they get the BT shunt, though, they can come off prostaglandins. Up until they get the surgical repair, they're going to be on prostaglandins to keep that PDA open, which used to be right here, to keep that PDA open for systemic blood flow. Now that we have the BT shunt, it's doing the work of letting blood into the lungs so we can close the PDA. And then, again, creating the new aorta using the pulmonary artery. So the goal of this is to improve their systemic blood flow. Next step is a bidirectional Glenn. So when they do this, they take away that BT shunt, and we're gonna have an even better way to get blood into the lungs. So they're gonna connect the superior vena cava directly onto the pulmonary artery. So this is a much bigger vessel. All of the blood returning from the upper part of the body is going to go directly into the lungs. They kind of sew up that connection. So the right atrium is now only being fed from the inferior vena cava, and then that ASD that's still feeding it from the left atrium. So blood flow here from the upper part of the body comes directly into the pulmonary artery. Oops. Blood return from the upper part goes directly into the pulmonary artery and lungs, and blood flow returning from the bottom goes into the right atrium. Then as blood flow comes back into the lungs from the left atrium, it still can't go into that left ventricle, that it's too big in this picture, but so it goes across the ASD into the right atrium. So that oxygenated blood from the left atrium mixes with the deoxygenated blood from the lower part of the body, goes into the right ventricle and out that new aorta, which used to be the pulmonary artery. Oh no, belly's up that. Okay, next step, which usually another question. Do you know how long the patient stays in each stage? Are they usually in each stage for a few years? The first repair happens pretty soon after birth. You cardiac people chime in. I know the third stage, Norwood, usually they have to be at least 2 years old. But can any of you cardiac people remind me when this second stage happens? Pop quiz. Let's see if I can Google it faster than you can talk. Anyone? All right, Caroline's gonna Google it, or 6 months. Thank you, Lindsay. So yeah, the first stage happens right away. Second stage with the Glenn will happen around 6 months, and then the third stage is usually at least 2 years old. They have to be kind of big enough. All right, so the third stage is usually just called a Fontan. You can call it an extracardiac fenestrated Fontan if you want to. That seems real fancy, but I just remember it as Fontan. But basically on this one, this is where they're also going to connect this inferior vena cava up to the pulmonary artery as well. So they'll kind of disconnect it from the right atrium, though they do create a tiny little hole. That's why it's called fenestrated, a fenestration conduit between the vena cava and the right atrium. So it allows a little bit of blood flow into the right atrium, which they found helps with having like post-op pulmonary edema or like too much blood flow initially into the lungs. So that's kind of like a little pop-off valve. But basically, at this point, the goal of this stage is to get all of the blood that's returning from the body dumping directly into the pulmonary artery, going to the lungs, comes back from the lungs into the left atrium, goes again across into the right atrium, into the right ventricle, and into that new aorta. So at this point, up until now, their SATs were mixed, or their blood was mixed, which made their SATs lower than normal. And at this point is when you should see a pretty much normal SAT. There's still a little bit of mixing here from the right atrium for that little pop-off fenestration. But for the most part, their SATs are going to be normal. All of this, I don't know how long kids live with a Fontan, but usually these kids eventually get, correct me if I'm wrong, but from my understanding, eventually you're still looking at some kind of either transplant down the road. Sometimes they need VADs. It depends. I'm not sure how long this is meant to last. But you will need to monitor long-term. These patients need to be monitored for that right ventricular function. Again, the right ventricle was never really intended to do the work of pumping blood to the whole body. So sometimes it can eventually fail. So you'll need to monitor their function moving forward. And just kind of remember that then all of the blood flow going to the lungs is passive with these repairs. Because there's no right ventricle that's pumping blood into the lungs anymore. All of it is passively coming back from the body into the pulmonary artery, into the lungs. All right, so those are all the defects. And now we're just going to do general principles of cardiac surgery and some things to look for. So first of all, with the family, I mean, this is a lot of times now a fetal diagnosis if they have enough neonatal or preterm care, but it's still a reality shock. You know, you're expecting a normal baby, and it's, you know, this, depending on the degree, can be a very lengthy and intensive process. So a lot of these kids are very fragile before and after surgery. It needs to be a multidisciplinary team effort. And a lot of them need multiple surgeries, long-term follow-up care. They can have medication regimens that are very complicated, and a lot of growth, development, feeding issues that need to be addressed as well. There are support groups available for these families, and some of them do need genetic counseling because, like I mentioned, a lot of these defects can stem from a genetic problem that they might want to, you know, evaluate for to see if future kids might be at risk. Social work needs to be involved to give them coping mechanisms and support, but also as a consult to evaluate their resources at home. They might need spiritual or religious counseling, bereavement counseling if the child eventually dies. And then if they have other siblings, there can be a lot of family dynamics as well. And they're going to need lots and lots of education. In general, when you think of these surgeries, you're going to want to think of what's the goal. Are we repairing? Are we getting back to normal? Or is it palliation? For instance, the 3-step surgery for hypoplasia is typically thought of as palliation. You're not getting back to a normal heart. You're making what they have as good as it can be. And then they might also need cardio, especially during surgery, depending on the repair they're doing. They might need bypass during surgery. So that involves hypothermia for myocardial protection. They basically, you know, stop the heart, cross clamp the aorta, do the repair, and then return blood flow to the heart. So in general, this is, you know, the same with a lot of post-op care, but you're going to look for hemorrhage, look for clotting issues. You're going to want to monitor their hemodynamics, their blood pressure, their fluid status, their ventilation. A lot of these patients might need to be mechanically ventilated for a while just to take the workload of their heart down until they can heal from the surgery. You're going to want to watch acid-base status and electrolytes, because again, electrolytes affect the heart. Acid-base status, you know, too much acid is going to affect the heart, so you're going to want to keep a close eye on that in the lab. And then again, arrhythmias, because a lot of these repairs deal with parts of the heart that have include the conduction pathways. Okay, moving right along. Again, there's a lot of information to cover, so it's kind of hard to get through all of it in these 2 hours. But so a lot of this, you're just going to have to kind of identify the areas that you're weaker in and do some self-study in those areas. But cardiogenic shock is the next one. So there's obviously, you know, there's a lot of different types of shock that we talk about: septic shock, anaphylactic shock, and we will talk about those later in a later review for multi-system. But cardiogenic shock, the main difference of this is it's shock because of cardiac function. Not enough cardiac function is decreasing your perfusion. So, you know, your heart starts to not work as well. It can't meet the metabolic demands of the body. It can't meet the metabolic demands of even the heart itself, which makes your myocardial dysfunction even worse. So it kind of cycles down to make it worse and worse. So you kind of want to stop that cycle and treat it there. The biggest thing you'll probably see about this, well, when we get to management, is with judicious fluid use, or in other words, don't give them too much fluid. Again, going back to that Starling's law, too much fluid with sick hearts is not good. It overloads the heart and makes it hard for it to pump. So cardiogenic shock can come from a lot of things. You'll see it a lot in those congenital heart disease babies, or because of some part of their repair and after repair. Or, you know, prolonged tachycardia even. When you, any of the itises we talked about, valvular disease, there's a lot of things that can cause cardiogenic shock. But the main thing to remember about it is that it's shock that results from a dysfunction of the heart itself. So how do you manage it? First, you want to minimize their oxygen demands as much as possible. So that involves intubating them, mechanically ventilating them, keeping them normothermic as much as possible. You don't want a fever. You want to sedate them as needed, give them pain management because pain is going to increase their oxygen demands, and then correcting anemia because you want as much oxygen carrying capacity as you can. Again, look for arrhythmias, optimize their preload. You do want to treat hypovolemia, but the big difference is you're probably going to start with a 5 per kilo bolus, not a 20 per kilo bolus that you give for septic shock. Want to improve their contractility, possibly with meds and inotropes, and decrease their afterload. So make it easier, decrease the resistance it's pumping against to make it easier. Look, and then you just need to look for causes and treat causes. So you're going to look for congenital heart disease, traumatic heart disease, and then target the cause. Obstructive shock, we don't see this as often in peds, but I'll just mention it because it is part of the test plan. But this is obstruction to cardiac output from some other problem. So either a pulmonary embolus, some kind of thrombus, valvular stenosis, aortic coarctation, and great vessel trauma. So those stenosis and coarctation are probably the more, that's that coarc baby that presents in shock or something, you know, that kind of thing. All right, cardiomyopathies. So this is any disease that, you know, that's a very generic term for a disease of the heart. But it can be, there's 3 main types. There's dilated, hypertrophic, and restrictive. The restrictive is more rare in peds. But dilated cardiomyopathy is the most common type in children. This is where you do an x-ray and you maybe didn't know they had any heart problems at all, and you see their heart is huge on the x-ray. That's a dilated cardiomyopathy. It's a dilation or an enlarging of the left ventricle. So that left ventricle gets way too big, and then it's just not able to pump effectively like it should. It's usually referred to as a congestive cardiomyopathy because since it's not pumping like it should, that blood is just kind of pooling there, which causes congestive heart failure symptoms. You know, think your kind of blood's then backing up and can cause either pulmonary edema if it's left heart failure or peripheral edema if it's right heart failure. On their echo, you're going to see decreased ejection fractions and stroke volume. Second, hypertrophic cardiomyopathy is a thickening of that wall. And like we said, a thickening of heart muscle is not good. We don't want to see the heart muscle getting larger because as it gets larger, its function goes down. And it also, as it gets larger, it's making less and less space for the actual ventricle, the open, you know, the cavity itself. The bigger it gets, the smaller that opening can be, which means less blood can get in to be pushed out. Usually this results from some kind of obstruction, either, you know, it's having a hard time pushing against either that stenosis or something, the valves, you know, not working like they should. And then restrictive, again, this is not very common in children, but this is some kind of defect in the anatomy of the endocardium. So some kind of fibrosis scarring, which is affecting how compliant the heart is and how much it can contract. So usually what you'll see on x-ray, especially with dilated cardiomyopathy, is cardiomegaly, so the large heart on x-ray. They may be asymptomatic. Like I said, sometimes these kids come in and they just kind of have general symptoms and you see this huge old heart. But as it gets worse, you may hear a murmur. You may see poor perfusion. Again, signs from congestive heart failure, low cardiac output. They might start having a drop off of their urine output. And then as it gets worse and worse, decreased level of consciousness, syncope, arrhythmias, and shock. So where it's diagnosed with an x-ray, you might also see changes on their EKG, delays in conduction as those, as that heart muscle's not working as it should, conduction can be affected. You'll usually do an echo to evaluate their function. Sometimes these can be caused by viruses, so you might want to check for viral titers, and then cardiac catheterization can really, this is more diagnostic to just look in depth at the function of each of the chambers and the pressures. So for management, you just want to, it's mainly symptom management. You want to decrease the workload of the heart. So that's going to be restricting their fluids, because too much preload is going to just put too much load on the heart that's already having a hard time pumping. So decreasing their fluids, DVT prophylaxis, because again, that pooling of the blood as it's not pumping very good is makes it too easy to clot or to form clots. And then monitor their activity. They might need a cardiac assist device depending on how bad it is, an LVAD or something like that. A VAD, I guess it depends which side. And they might need transplantation. For dilated cardiomyopathy specifically, some inotropic agents to help with squeeze can help. But one of the biggest ones you'll see is milrinone to reduce afterload and help with squeeze. Vasodilators can help too, that helps it make it easier to push against, and again, diuretics to make so they're not too fluid overloaded. For hypertrophic cardiomyopathy, beta adrenergic agonists, calcium channel blockers, because those help with afterload reduction, they decrease contractility. Diuretics, pacing, if they have asymmetric function. So sometimes if it's just one side of the heart that's too big, you can kind of have asymmetric function, and pacing can help with that. And then sometimes they need surgical resection to take out that extra bulky part of the heart. And then restrictive, there's nothing specific, it's just symptom management. And again, this is not that common in kids. Just a couple things about cardiac catheterization, things to think about. In case you're not familiar with it in general, this is where they go through usually the femoral vein or artery, depending on which side of the heart they want to look at. They thread a catheter all the way up into the heart, either to just evaluate and look at function, or sometimes to correct things, to do balloon dilations or stents and things like that. So post-op or post-procedure, you're going to want to look for arrhythmias, depending on how much where they're poking around in the heart can cause arrhythmias. A big one's hematoma, especially at the groin femoral site. So they need to be flat for, I think it's 4 hours, and not moving. And you're going to want to monitor their pedal pulses and make sure they're equal. But they can also have clots, shock, acidosis, death, same dramatic stuff as every other thing. Dysrhythmias, I'm not going to get into too many of these because we're running out of time, but the biggest thing to look for or to review is your PALS review. So all of the arrhythmias and algorithms that you go through in PALS of different, wide complex tachycardias and things like that, that's what you're going to want to review. But this is my one little meme that I got into this one. If you wink at me, I winky back. So in a nutshell, conduction is, the AV node or the SA node is your pacemaker of the heart, the sinoatrial node that's kind of at the top of the atrium. It sends a signal to your AV node, which then sends it, down through the ventricles. And so if you can have problems where it's too fast, where it's too slow, where your atria and your ventricle aren't really talking to each other like they should. And with any of these, you can have, it happening with or without a pulse. Again, I'm going to kind of skip some of this because it's review, but you're going to want to go over like what each part of the rhythm should be. And that's this pathway that I just talked about. It goes down through the ventricles, the bundle of His, into the Purkinje fibers, and depolarizes the entire ventricle. The biggest terms to remember is depolarization. That's when squeeze happens, and then repolarization is the reset of those things as it's during diastole getting ready to squeeze again. Again, I'm going to kind of skip. This is one they like to ask about, Wolff-Parkinson-White. So this is a problem, a birth, a congenital accessory pathway problem. It's an alternate way of conduction that is usually faster than the AV node. And this doesn't show up all the time, but sometimes it can kind of get triggered to show up, and then cause tachycardia, palpitations, lethargy, syncope, seizures. So you use beta blockers for this, ablation, no digoxin. I'm not sure why she said that, but if you see a question about delta waves, it's probably Wolff-Parkinson-White, because that's a pre-excitation of the ventricles. So they're getting excited before they should because of that congenital accessory pathway. Long QT syndrome is another thing you might see a question about. So this is just a problem in the ion channels of the heart. It's basically a problem with prolonged ventricular repolarization. So the ventricles are taking too long to reset, which then is a problem if then the atria is trying to, the SA and AV node are trying to cause depolarization before they've reset. So you kind of get an R on T situation, but this puts them at risk for torsades. So basically think long QT syndrome, at risk for torsades. Some people can get this from exercise, specifically swimmers for some reason. And treatments for this would be managing the cause of it, beta blockers, sodium channel blockers, increasing their potassium in their diet. They might need denervation surgery or a defibrillator if they're going into torsades a lot. And then you want to avoid, the one question I saw when I was going through review is avoid meds that prolong your QT. So Benadryl, Zofran, amiodarone, methadone, those are all common examples of things that prolong your QT syndrome. And then blocks, I'm not going to go through blocks, study AV blocks on your own. There's first degree, second degree, type 1 and 2, and third degree. Pacemakers, they might ask you a question about pacing, and I have a review question if we can get to it that does have pacing in it. But basically just remember, this might be something you want to look at on your own, but there's going to be it's going to sense something, either your atria, ventricle, or both. It's going to then trigger another part, either your atria, your ventricle, or both. So which chamber is it pacing? Which chamber is it sensing? Which one is responding to the sensing, and how you program it? So I have a question later, but review that. That's going to be another thing, homework review on your own. Cardiac failure, we've talked a little bit about congestive heart failure and stuff as a reference to other things, but this is just kind of a general term of a failure of the heart. It can be left side versus right side, and it's going to look different versus one. If the left side of your heart's failing, it's going to make the blood back up into the lungs, which can cause pulmonary edema, pulmonary problems. And then the right side of the heart, if it's failing, can cause back up into the body. And if you have pulmonary problems that's making it hard for the right side of the heart to pump into the lungs, that can then cause retrograde right side heart failure. So treatment of that, you want to maximize cardiac performance, decrease myocardial oxygen demand, bed rest, meds, things like that. Hypertensive crisis. This is the last major thing we're going to talk about, but it's basically hypertension is blood pressure more than 95th percentile for age, sex, and height on at least 3 different occasions. And a hypertensive crisis is a life-threatening acute elevation in your blood pressure. It can cause organ damage, death. You'll probably see a question, if it's related to this, about meds like nicardipine to deal with that. Causes can be from renal issues, because and things in your renal system in general have a lot of regulation on your blood pressure. So if you're having problems with your kidneys, those hormones could get out of whack and make your blood pressure shoot up. Neurologic causes include increased ICP, Guillain-Barré syndrome, and other familiar patterns of hypertension. Like you might see some I've seen random study questions about a pheochromocytoma. So you might want to look up what that is. It's basically a tumor that secretes a hormone that causes increased blood pressure. So cardiac meds, we don't have time to go over them today. I'll send out some review points probably tonight about some ones you might want to look at. But some of their favorite subjects are digoxin, digoxin, digoxin. Somebody who took it recently told me there were like 3 questions on digoxin, which percentage-wise is kind of a lot. So make sure you look at that, about why you'd give it, especially the overdose symptoms, like photophobia and halos and all that kind of stuff. And then some of the labs you'll look at, like potassium levels and PR intervals and stuff. They like to ask about propranolol, nicardipine, again, for blood pressure management, hypertensive crisis, and milrinone for heart function. Okay, so with the time we have left, I want to go through some practice questions, because again, I feel like this is the most helpful. And sorry for rushing a little bit. There's just a lot of information in this section, especially to be, 14% of the test is about 21 questions, which is, just being one system is relatively a lot. But cardiac, especially for those of us who aren't cardiac nurses, can be a little daunting, and it's, complex. So I apologize for not being able to get in depth about everything, but again, just kind of identify the stuff you're not as familiar with, and then focus on that. All right, so let me try to get these poll questions set up. No. First question, well, the first 2 we're going to do together to kind of talk it through and talk about how, even if you're not sure about the answer, how you might be able to think it through and figure it out. So first of all, an ECG or EKG of a child requiring ventricular demand pacing, VVI pacing, demonstrates pacer spikes and ventricular depolarization. The patient's intrinsic rate is greater than the rate set on the pulse generator. This pacing over the patient's intrinsic rate is due to what? So I looked at this question and I had not reviewed pacing in a while. So kind of my thought process of going through this, I'll open this poll just to see, oops, if y'all want to answer it, hold on. No. I'll let y'all think about it while I figure out where these questions are. Okay, so let me open this poll. So they are on ventricular demand pacing, VVI. So V, it means it's sensing the ventricle and pacing the ventricle. If their intrinsic rate is greater than the rate set on the pulse generator, then what is the problem? So let's see, I'm gonna go ahead and answer it. So as I'm thinking through this one, I'm kind of trying to break it down like, okay, it should be sensing their ventricle, and their rate is greater than what's set on the pulse, but you're still seeing a pacer spike and a ventricular depolarization. So it's under sensing their ventricle. It should be sensing their ventricular rate and only really pacing them if their rate gets lower than what the rate should be. So this means it's under sensing. So just that needs to be adjusted, and the sensing turned up, I guess. So basically, VVI is placing the ventricle ventricular sensed and inhibiting mode. So it's a single chamber demand pacing. When it senses a beat, the pacing's inhibited. So it's only going to pace when the rate gets lower than what it's set at. So when their rate is higher than what it's set at, it lets their heart rate be higher. When it's lower, then it paces to keep up that minimum rate. So if it misses sensing that, it's not going to inhibit the pacemaker, and the pace, it could be too frequent or irregular delivery of stimuli, because it could still be trying to pace them, have a heart rate going on at the same time, and that's not good. All right, next question. It looks like, let me close it out. Oh dear. We get music ready for the next one. So most of you got it right. I was talking through it. We can start reading through this one. This is a pretty long question. And whenever you see really long questions like this, I mentioned this in the last one, but kind of go ahead and do yourself a favor, skip to the end and see what it's going to ask you. This one, unfortunately, asks you a very general question, so we're going to need to really think through a lot of this information. So the question is going to be, what's the most probable etiology of their cardiopulmonary status? And we'll see the choices on the next slide. But so basically, a 10-day-old infant admitted with suspected congenital heart defect, and they have a history of poor feeding and a sudden onset of respiratory distress and cyanosis. So initially, their blood pressure is 48 over Doppler, CO2 is 30, heart rate's 180, O2 is 48, respiratory rate 68, bicarb is 16, and their pH is 728. They're intubated and placed on a mechanical ventilation. These are the settings which, I think I forgot to type in the one most important setting, FiO2 of 100, rate of 20, PIP of 24, and FiO2 of 100. And their post-op, the post-op gas basically has all these things, including a PO2 of 50. And that's those are the most important parts. So in looking through, I didn't get all of the information in here, but in looking through, basically the only big change on the post-op gas, there wasn't really a big change. The O2 is still 50 on a FiO2 of 100, and other stuff basically unchanged. So you would think a baby comes in with respiratory distress, and they have, you put them on a ventilator and 100% FiO2, you would expect that gas to get better, and it doesn't. So what is their most probable etiology? So a coarctation of the aorta, a hypoplastic left heart, a transposition of the great arteries, or a tetralogy of Fallot. So in thinking through this, you're going to want to think of things that increasing their oxygen doesn't help. And the main one and most common one of this is a hypoplast. So 10 days after birth, this is kind of still in the time frame of when the ductus arteriosus is closing, especially when it's anatomically closing. So that's going to increase their pulmonary blood flow and decrease the aortic flow. So that's why they show up with a blood pressure of 48 over Doppler. They have very poor systemic perfusion. And then even if you give them extra oxygen, that's going to improve the blood flow to the lungs, but that's kind of just going to be in a circle from heart to lungs, heart to lungs, heart to lungs, and it's still not going to get out to the body. So when you draw a gas from their body, even with that mechanical support and the oxygen, their gas is going to be unchanged and not improved. So that's kind of how you can work out that answer. All right. All of these other ones are going to be poll questions. So let me, as you're reading this, pull this up and open it up. And I've got some Jeopardy music this time to remind me to give you enough time. There she goes. Okay, so junctional rhythms are caused by a dysfunction of the sinoatrial SA node, and typically cause, is it A, a shortened PR interval, B, a regular ventricular rhythm, C, prolonged QT interval, or D, widened QRS. So junctional means that main pacemaker, the SA node, is not working like it should. then the pacing of the heart is coming from further down the pathway, and the further down the pathway, the slower your heart rate gets. But it doesn't necessarily get more irregular. So a junctional rhythm is coming from that junctional area, and instead of it going from atria to ventricle, that junctional rhythm kind of has to send it to both the atrium and ventricle. So what you get from that is actually a shortened PR. Or is this correct? I thought it was a shortened PR interval. I think this is wrong. I put widened QRS because I wasn't.
That might be the one we went back and changed.
Yeah, I wasn't remembering it correctly. I was thinking, well, junctional rhythms are coming more from the ventricle, so it's a wider, but it's not. It's still regular. It's still narrow because it's still the pathway is still happening quickly. So it's a shortened PR interval, and you can see.
Sorry, that was my bad thought.
You can see in the explanation, it's correct. The impulses are generated in the junction rather than the SA node, so it goes in two directions. And the backward retrograde is going to make the shortened PR interval. The forward one has a QRS. The heart muscle is still it's acting normally, so it's still not. It's still a narrow QRS. It's just coming from both directions, and it's usually a slower rate than it should be. Okay, sorry about that. That was it. She messed that up because I got it wrong. All right, next, and it looks like, yeah, most of you who answered got it right. If more of you are welcome to answer, only 9 responded to that one, so.
We don't know who guesses what.
Yeah, I don't know. I have it so it doesn't show me who's guessing what, so it's not, I'm not going to see or judge you if you get it wrong, just like I got it wrong. But that's why it's important to really, even if you don't know and you can't remember, just thinking, oh my goodness. Belle, whenever her water is empty, she just digs at the metal bowl and makes that sound you just heard. Sorry about that. Okay, here's the next one. Patients receiving continuous infusion of alprostadil, Carverject, which is also, in case you don't know, PGE. So that's another one they really like to ask about, so make sure you know all the names of that. But usually they'll either say PGE or alprostadil. Prior to cardiac surgery. So we're needing to keep open their PDA for some reason. They must be monitored for what? And this is probably one I'm going to guess our cardiac nurses know. And unless you know this, you're probably not going to figure it out, to be honest with you. This is one of those you know by being familiar with this drug and what one common side effect can be. So I'm going to go ahead and start to close it out. Oh, more people participated. Thank you. Forgot my Jeopardy music that time. This might run a little bit over. It won't hurt my feelings if you have to go. But if you want to see I've got about 10 more practice questions. If you want to see them all, you're welcome to stay. If not, if you have to go, I understand. All right, so most of you got it right, probably mostly the cardiac nurses, but this one is apnea. So it maintains the patency of that ductus arteriosus, keeps allowing that blood to shunt to help whatever, cardiac defect that needs that blood flow until they can get to surgery. But apnea, it typically causes vasodilation, leading to hyperthermia, hypotension, and flushing, and apnea is seen in 10 to 12%. So this is probably if you use that med a lot, to look out for that. So next question. A 3-year-old is admitted with chest pain. Let me load this up while you read it. Can you help me find which question? Number 2. No, we're on 4. Okay, here it is. A 3-year-old is admitted with chest pain, dyspnea and fatigue. Nurse notes occasional PVCs on the cardiac monitor, which finding would support a concern for a weakened myocardium. So go ahead and give it your best guess. I'll give you time to kind of think it through. Does she have water?
I gave her water.
Oh, puppies.
She's dramatic.
She's very dramatic. It looks like a lot of you are kind of guessing what I guessed. And again, all of these practice questions came from the AACN, so I kind of did what I did last week and picked the ones that I thought were tricky. Or not intuitive, I guess, but to show how you might want, takes a little more thinking through, but sometimes you just have to know it. So the answer that they gave was actually pulses alterans. So that's an alteration of strong and weak pulses, which indicates an alteration of strong and weak contractions in the myocardium. So when the myocardium becomes too weak, either because of infection or inflammation, then you can see, intermittently strong or weak pulses. So tachycardia usually would be due to other things, not necessarily a weakened myocardium, but that's more like fever, dehydration, increased oxygen demand. And then on a large cardiac silhouette and central venous pressures are results of congestive heart failure or that cardiomyopathy. But so I don't know. I thought this question was tricky, and I'm sure we could debate which one's right. But according to the AACN, it's pulsus alterans because it's showing an alteration between strong and weak contractions. Did someone have something to say, or was that just a... Okay. All right, next question. Moving along. Here we go. So again, this is one they like to ask about. And with PDAs, you kind of have to think of it as a two-sided. You either want it to be closed because it doesn't need to be open, or you want to keep it open because they have other defects. So this one has the one, you're going to see both those in the answers, and you got to just remember which one's which. It's kind of a memorization thing. All right. So some of you did fall for the tricky one and say PGE, and that's the one that keeps it open. So it's asking for the medication in order to close it. So that's going to be indomethacin. And again, that's just something you have to memorize, but they do like to ask about it and try to, again, like trip you up as like, which one opens it, which one closes it. Prostaglandin opens it, indomethacin closes it. And it's most effective when administered within 10 days of age. All right, next one. 5, 6. Okay, a patient's admitted with bradycardia, hypotension, photophobia, and lethargy. The caregiver reports a history of SVT. So the nurse should suspect symptoms in response to which medication? So kind of mainly focus on those symptoms at the top and think which medication would that be from too much of, possibly. Go ahead and start. I'll go ahead and close it and move on so we can get to more without going over too much. But yeah, this one's digoxin. And again, you're going to want to really...
And everybody that answered got it right.
Yeah, everyone that answered got it right. Good job. They like to ask about digoxin, so... It doesn't mean it's always going to be the right answer, like on the last question, but make sure you review it. All right, a child's admitted 1 week after device closure of a ventricular septal defect via cardiac catheterization. The most common dysrhythmia seen after this procedure is, and this one, you might be able to figure it out without knowing, though I tried to overthink it and I think got it wrong. So what kind of these three, which dysrhythmia would you expect to see after closure of a ventricular septal defect? So they're doing a lot of work inside the ventricular septum. So In case you need a little visual after the long 2 hours, Belle says, hi, you did a great job. All right, so here's the results. Ooh, kind of across the board. But according to the AACN, the most common one is a third-degree AV block. So if you think about the fact that they really did a lot of work in where that conduction is trying to go down to tell the ventricles what to do, you can see it can get just completely interrupted and cause a complete dissociation with, you know, the atrial contractions and the ventricular contractions. So I think on this one, I was thinking, oh, most common, they'll probably see PVCs or something because you irritated it. But according to the AACN website, the most common, okay, she's too excited. The most common one after this is going to be a third-degree AV block because those cannot, you know, communicate with each other anymore. All right. Next. The nurse is carrying, let me open this up. The nurse is caring for a patient with palpitations. On the ECG, I always want to kill EKG. Delta waves, shortened PR intervals, and inverted T waves are noted. So what do you think it is? All right, most of you got it right. It is Wolff-Parkinson-White. So again, delta waves. I don't think that's the only thing that has delta waves, but if they're asking about delta waves, it's probably Wolff-Parkinson-White. Okay, and I'll send out these because I think the slides I sent out last night didn't include these questions. I'll send out these questions again so you can read through all the rationales. We go ahead and start reading this next one. All right, so a 15-year-old patient underwent a classic Fontan, and maybe I'll pause right here. Maybe one of you cardiac people tell me how a 15-year-old got to the point where he needed a Fontan. How does that happen? I thought that was way too severe to last till you're 15 years old, but and I associate Fontans with younger patients. But anyway, a 15-year-old patient underwent a classic Fontan, and I'm being serious. Like, I would like someone's input on how often 15-year-old gets Fontans for tricuspid atresia, which I thought was pretty severe. So they underwent a Fontan 12 hours ago. They're cool, diaphoretic, restless, modeled peripherally, no pedal pulses, and faint femoral pulses. Heart rate's 140. Their MAP is 60. Of course, this is a 15-year-old, but CVP is 20. SVR 2000. I honestly don't know what the normal SVR range is. I would have to look that up. But what do we think is probably happening? Main point, they're 12 hours after a pretty intensive cardiac repair of a defect. So most likely, what do we think it is? Looks like the two most popular answers are the ones I was kind of between. But I'll show you what they said the answer was. No cardiac person wants to tell me how often a 15-year-old gets a Fontan. I'll have to Google it then. I was hoping for never. Thank you, Lindsay. I read this question. I'm like, should it be a 15-month-old? I double checked a couple times and it said 15 years. So, all right. So we're kind of split on the answer here, but it is cardiogenic shock. So anytime you have those, you know, cardiac defects or something affecting the function of the heart, you can see cardiogenic shock, but especially right after what is usually a pretty significant and complex repair. So usually after a Fontan, low cardiac output's the most common and severe complication, and it's caused by inadequate blood flow into the pulmonary circulation, resulting from hypovolemia and inadequate systemic venous pressure, blah, blah, blah. So I could see how cardiac tamponade could also be a risk because, you know, there could be bleeding in and around the heart causing a tamponade. but according to them, it's cardiogenic shock. So, all right, next question. Oh, thank you. Thanks, Will. And I know some of y'all have to go. I have to work tonight as well, so I'll see you at work tonight, Will. But yeah, don't feel bad if you have to get off the call. I know we're going a little bit over. Okay, so a hypertensive crisis, as evidenced by acidosis, hypothermia, and alveolar hypoxia, may be demonstrated in which types of patients? So, this, we talked about hypertensive crisis as a systemic, like general hypertensive crisis, but you can also see this in a specific part of the body, which I'm kind of trying to give away the answer. Okay, we'll go ahead and start closing it out. Finish up your answer if you've started it. All right. So most of you got it right. It's a reactive pulmonary bed. So this is, think a pulmonary hypertensive crisis, like in our PAH babies. So those with pulmonary vascular disease are at high risk for developing a pulmonary hypertensive crisis. And that includes acidosis, hypothermia, and alveolar hypoxia. So sometimes acidosis can trigger a hypertensive crisis, but yeah, it's a reactive pulmonary vascular bed. Good. Here's the next question. And I've just got 3 more. And looks like I hit my recording limit, so those who are watching this later are going to miss the last few. A patient presents with episodes of intermittent palpitations associated with weakness. EKG reveals a heart rate of 125, a shortened PR interval, and a slurred upstroke before each widened QRS. The slurred upstroke delta wave. So this is, we kind of already talked about this and asked about this, but it's specifically asking what is happening with that delta wave. So go ahead and answer. Okay. All right, so looks like pretty much all of you got it right, but it's that ventricular pre-excitation. So the delta wave, in Wolff Parkinson White, it's because of that congenital abnormal conduction system, but the ventricles are getting excited too early, usually from that other alternate pathway. Okay, good job. Just a couple more. Right. Patients admitted with a history of high fever for 2 weeks, strawberry tongue, swollen hands and feet, and a rash throughout the trunk. Echo shows dilated coronary arteries. The nurse would anticipate administration of which antithrombotic? So, it's like a lot of you have answered, so start to close it. And you got it right. Good job. It's aspirin. So that, again, strawberry tongue should kind of, the rash, trigger Kawasaki in your brain. And aspirin is what is used for that one specifically. Last one. Okay. A nurse is caring for a patient who had a syncopal episode. The nurse should be concerned for acquired long QT syndrome if the patient is currently taking which of these medicines. So this, you're just going to have to be, again, go over cardiac meds because they do like to ask about it. It's just too much to go over in this 2 hours along with everything else. But which of these can cause prolonged QTs? And I couldn't remember on this one. It looks like a couple of you guessed it. I kind of thought Reglan might be as well, and I wasn't sure about Wellbutrin because I know, I don't know. For some reason, I thought Reglan was, but it's Zofran specifically. But methadone causes prolonged QT. Other things include macrolides, quinolones for antibiotics, lithium, antiemetics like Zofran, or antidepressants. So that's all I got for you. I really appreciate all of you joining me today. Sorry about the little bit of technical difficulties. But I will send out tonight the practice question, this slideshow of the practice questions and information about meds you might want to cover in your self-study. And then hopefully sometime this week, sooner than Sunday night at 2 a.m., I'll send you out the info for next week's session. Next week is the pulmonary review. And so I'll try to work on that and get it out midweek, hopefully. But it'll be same time, same login, WebEx information, again, 3 to 5. So I hope to see you all then. This recording, you can let your friends know, will be up again for a week until next week. And I am saving them to hopefully somehow have available for later. But if you know anybody who missed it, they can watch the recording this rest of the week. But thank you guys so much. I appreciate you joining me and taking the time. So stop. I'm going to go ahead and go. I'll see some of you at work tonight, I'm sure. Bye.